Yeah. Can we start?
No. Okay, yes.
Yes, please start.
Okay, start. Just
Please start.
Good evening, everyone. A warm welcome to ISA National. These classes are held on Monday and Tuesday at 6:30 p.m. I'm Dr. Ruchika. I'll be the screen coordinator for today. I'm presently working as senior resident in JN Medical College, Belgavi. Today's session we'll be discussing about orthopedic trauma case presentation. Before we begin today's class, let us invoke the divine blessings of Lourdes Saraswati, the goddess of knowledge. A warm welcome to all of y'all for this PG class. I would like to invite the Honorary Secretary, Dr. Rajiv Gupta sir, to say a few words.
good evening, everyone. Respected faculty members, my GC colleagues, screen coordinators, my speaker, Dr. Arundhati, and my colleagues. Welcome to this fourth PG ISA online class for the topic of orthopedic trauma. Dr. Arundhati will be presenting the case. We all know that orthopedic trauma, it's in abundance. Most of the people, most of us have faced orthopedic trauma in various kinds. Like it could be a simple trauma, it could be a high energy, low energy trauma. So what we have to see in patient is the best thing, how to take the history, how to see a patient, what is the clinical evaluation, patient's vitals, what are the vitals, patient is conscious, unconscious, or so many things we have to see. So let's all discuss about it and let Dr. Arundhati take the case and present it. Thank you. Over to Ruchika.
Yes.
Good evening, one and all. A very warm welcome. I myself, Dr. Rakhi Mohan, currently working as registrar at SP Medifort Hospital, Trivandrum, Kerala. I'm indeed honored to be one of your screen coordinators for today. The goal of today's class is to provide a comprehensive, focused, and interactive learning experience. So, to ensure a smooth, productive, and respectful learning environment for everyone, we have a simple but important guidelines we ask all the participants to follow. We request everyone to keep your microphones off during this session. This is to prevent background noise interference. And please keep your videos off. So it will foster a more engaging and connected community experience. There should be no interruptions during the presentation. Please type your queries in the chat box, which will be cleared later. Your cooperation in following these rules is greatly appreciated. With that, let's dive into the session. Now, I would like to extend my very warm welcome to all our distinguished faculties for the day. Now, to start with, Varshali ma'am. Dr. Varshali M. Kenya. Ma'am is a professor and head of the department Anesthesiology in charge OT services, Bharati Vidyapeeth University Medical College, Pune. She has a total PG teaching experience of 25 years. Her areas of interest include regional anesthesia, pain medicine, fluoroscopy, and USG musculoskeletal pain intervention. Her achievements include Fellowship of Academy of Pain Medicine, Fellowship in Chronic Pain, and she was awarded first prize for the paper presentation in state conference. She has 18 publications to her name. We welcome you, ma'am.
Thank you, Dr. Rakhi.
Next, our faculty is Dr. Shubhada S. Affib. Ma'am is a professor at Bharatiya Vidyapeeth Deemed University Medical College, Pune. She has a total PG teaching experience of 29 years. Her specialty of interest includes OBG anesthesia and medical education. Her achievements include FAMA Fellowship in Medical Education field, and she was recently facilitated for outstanding contribution at institutional level. And she has won first prize and gold medal for poster in National ISA Conference. And she has 15 publications to her name. We welcome you, ma'am.
Thank you so much.
Our next faculty presenter is Dr. Madhuri Sanjeev Madekar. Ma'am is an assistant professor anesthesiology at Bharatiya Vidyapeeth Deemed University Medical College, Pune. She has a total PG teaching experience of 22.5 years. Her specialty of interest includes pediatric, OBG, and regional anesthesia. Her achievements include Fellowship Course in Pediatric Anesthesia 2021, Safe Pediatric Course Jan 2021, Advanced NRP Provider Course 2023, Faculty in CME Essentials of Pediatric Anesthesia 2025. And she has 3 publications to her name. We welcome you, ma'am, to the session.
Yeah, thank you so much.
Now, I request Varshali ma'am to introduce the presenter for the day. Over to you, ma'am.
Good evening, everyone. So, Dr. Arundhati Sharma is our third year PG resident. And as we all know that orthopedic surgery or orthopedic surgeries amounts to a major chunk of our anesthesia and OT. So here we selected orthopedic trauma case for today's discussion. And I would request Arundhati to go ahead with her presentation. Yeah, over to you, Dr. Arundhati.
Thank you, ma'am. Good evening, everybody. I am Dr. Arundhati, and I'll be presenting my case on orthopedic trauma for the day. My case begins with a 24-year-old male presented to the emergency department on 25th December 2025 at 11:30 p.m. following a road traffic accident due to collision of a truck with a two-wheeler while he was a pillion rider. The accident took place around 8:30 p.m., following which he complained of swelling and bleeding over the right thigh and leg. The patient gives no history of loss of consciousness, event amnesia, vomiting, seizures, or ENT bleed. The emergency department workup included ECG, which suggested normal sinus rhythm, a CT brain with normal study, and VBG showing normal parameters. Following the scans, the diagnosis of right distal femur fracture with patella, fibular head, and medial malleolus fracture was interpreted.
Dr. Arundhati?
Yes, ma'am.
Yeah, you have presented this case scenario as it came to EMD, Emergency
Yes,
Medicine Department. Orthopedic trauma can be encountered by anesthesiologists at various levels, right from EMD for resuscitation, for intubation, to ICU, to OT, for damage control, as well as for definitive repairs and everything. So this is a case where your patient had a um, mm, he was a pillion rider and collision with the truck. Now, what other, you have said that this is a minimum EMD workup which they do immediately, but what other possibilities can be there when such a patient comes? Okay, this is a young patient, two wheeler, pillion rider, collision by truck. What other possibilities can be there when this patient, such a patient can come?
So, ma'am, if an RTA patient comes to us to the EMD, there can be a possibility of polytrauma. There can be a possibility of cervical spine injury. There can be massive hemorrhage. There can be um injury to the chest, to the lungs, to the abdomen, head injury. These all are considerations that can be present in a road traffic accident patient.
Right. I can add to that is, unstable cervical spine or even a maxillofacial trauma,
Yes, ma'am.
facial fractures. We might have to intubate depending upon the unstable
Yes,
or stability of the hemodynamic or otherwise stability of the patient. In
yes,
that case, airway management also becomes a problem, or very long bone fractures and displaced fractures. We may need to, though it comes late, we have to have a strong index of suspicions otherwise. Okay, so respiratory wise and other, as you mentioned already, head, chest, abdomen, all these trauma can be there. Anyway,
yes.
what further history you can elucidate in such a patient, which is very important for a polytrauma patient? We'll just see the scenario in a polytrauma, though
Yes,
this is
ma'am.
an isolated femur.
Yes, ma'am.
Yeah.
Ma'am, the patient might be unable to elicit the complete history due to numerous reasons. He can be in immense pain, can be hemodynamically unstable to elicit history, can be under influence to tell about the event that led to the injury or any other history pertaining to the patient. This is something I can expect in a polytrauma case.
Or there can be even head injury. The patient
Yes,
might
ma'am.
have
So, obtunded
been
mental
completely
status. Yes, ma'am.
obtunded, or somebody passerby
Has brought.
gets the
Yes,
patient. So all
yes,
this you
ma'am.
may not be able to get a complete history.
Yes,
Okay.
ma'am.
And any other things, any other, so how will you go by proceed with this patient for management, the emergency management in such a case? So what protocol normally you follow?
We usually start with the ATLS protocol. So
Hmm.
I would begin with the ATLS protocol considering the primary and the secondary surveys. So my primary survey will include the assessment of A, B, C, D, and E, where A stands for airway, B is for breathing, C is for circulation, D is for deformity, and E is for exposure or environment.
Yes. Okay. So
Yes,
once you do this, this is all very important and urgent things, especially airway, breathing, circulation.
yes,
Okay.
ma'am.
And then possibly you need to go, once you know what is the primary survey is completed, you will go to the secondary
Secondary
survey.
survey.
So
Yes,
what are
ma'am.
the components of secondary survey?
Secondary survey is usually done after completion of the primary survey, and we have made sure and we have dealt with the life-threatening conditions such as seizures or any fatal bleeds. A
Mm.
secondary survey check is done once the patient is responsive, and it is done to check for any other injuries of the patient. It will consist of a mnemonic called as AMPLE, which will consist of allergic history, any medications that the patient has been taking, any past medical histories that are relevant, any the last meal of the patient, and the event that led to the injury. However, in my polytrauma patient or any trauma patient, I will consider my patient as full stomach, as trauma patients, gastric emptying is delayed. So even if my patient is covering an NBM of 6 hours, I will still consider my patient as non-NBM.
Yes, that's right. The trauma patients, because of severe pain, or sometimes we do not know even what is the status of
Yes,
nil by
ma'am.
mouth. So we consider them as full stomach patients. So this is history. Physical
Yes, ma'am.
examination is always said that targeted physical examination. So
Yes,
if
ma'am.
you go by the targeted physical examination, what does it mean actually? Suppose if you
Ma'am,
consider hemodynamics, how will you go for that?
ma'am, in hemodynamics, we will look ahead and we will check the vitals, the pulse rate, look for tachycardia, look for hypotension, look for mean arterial blood pressure, mean arterial pressure. We look for capillary refilling time, urine output, and mental status, of course, of the patient.
Yes. And they have also mentioned diagnostic studies, especially in EMD. This all
Yes, ma'am.
happens in EMD. So, what diagnostic modalities you can do there?
Ma'am, we can run a FAST for the trauma patient, that is focus assessment in sonography in trauma patients. This
Right?
will rule out any solid organ injury, any free fluid in the pericardial or abdominal cavity, that we can rule out with FAST. And we can use EFAST, that is the extended version of FAST, to rule out hemothorax and pneumothorax. We can go ahead with diagnostic measures like ABG and yes, ma'am.
Maybe other things like HemoQ can be there, or
Yes,
even
ma'am.
you can think about volume status,
Yes, ma'am. We
isn't
can
it?
do an IBC screening for knowing the fluid status of
Yes,
the patient.
collapsibility index. So, with
Yes, ma'am.
all this, suppose if you get a, what about, what is your concept of knowing the hemoglobin here?
Ma'am, so in a trauma patient, especially a young patient that has met with an RTA or a trauma, initially on initial hemoglobin parameters will be normal because there
Mhm.
is a compensatory mechanism that will lead to hemoconcentration. But as soon as we resuscitate the patient throughout the stages of resuscitation with colloids and crystalloids, there will be
Right.
dilution that may result in the real value of the HPs will be actually in the decreasing trend, and we can identify any internal bleed if there is.
Absolutely, that's the thing. And then you have talked about indications for urgent or emergency surgeries. There's something called as damage control surgery, the
Yes,
word
ma'am.
which normally comes. What is that exactly, damage control surgery? What do you mean by that?
Ma'am, so damage control surgery refers to prioritizing any emergency limb-threatening or life-threatening injuries prior to any definitive treatment.
Right.
So there's a shift from anesthesia management to the damage control surgery.
So the plan shifts.
Yes, ma'am.
Okay. Yeah. So can you just give example of damage control? Maybe in your case,
Ma'am, in my case, the damage control was done by external fixation in the EMD itself. However, there can be other ways of damage control in the way of wound debridement or fasciotomy in cases of compartment syndrome. These are all examples of damage control surgery.
okay, can you just elaborate and share the slide?
Yes, ma'am.
Yeah.
Yes, ma'am. So
Hmm.
damage control surgery consists of 4 phases. There is a phase 0, which is the pre-hospital stage and emergency response, which will include primary care of the polytraumatized patient and control of any compressible bleeding and initiation of massive blood transfusion protocols. The phase 1 includes bleeding control or contamination control or temporary closure, which is carried out in the operating room, and this stage must be fast and precise. Phase 2 consists of the revival phase, which is performed in the ICU. The main objective here is to restore hemostasis and reverse the diamond of death, that is hypothermia, coagulopathy, acidosis, and hypocalcemia. In the ICU, we can also opt for any invasive lines or large bore IVs that need to be secured as per the patient's requirement. Phase 3 consists of definitive treatment or early total care, which is returning of the patient to the operation theater to perform an anatomical repair, which is the definitive treatment for the trauma.
Okay. So for all this, you will require some communication with surgeon.
Yes,
You
ma'am.
know, what is the timing of the surgery, what is the urgency of the surgery, and so on, so forth. So how will you do that surgical coordination?
So the surgical coordination has to be done at every step of the damage control. We need to know from the beginning, need to make multidisciplinary communication among the anesthesia and surgery teams. The
Mhm.
planned procedure or procedures and sequence of procedures, including the early placement of continuous peripheral nerve blocks for pain control prior to definitive procedure. We need to discuss
Right.
the urgency of surgery. We need to discuss the intraoperative positioning, expected blood loss, expected duration of surgery, and if there's going to be any use of tourniquet.
Yeah, you have mentioned about continuous peripheral nerve blocks for pain control. That's
Yes.
a very important thing because the patients are in agony. They may not be able to cooperate with you. We may not be able to shift them to the diagnostic modality centers or place. So in that case, what we need to do is there's something called as on arrival blocks.
Yes, ma'am.
So are you aware of such a concept?
Yes, ma'am. On arrival blocks are usually important for trauma patients because the patient is in immense pain. So there is difficulty in eliciting a history from the patient because the patient is in agony, like you said. The patient cannot be transported to the diagnostic centers for intra-hospital transportation because of the pain, which we need to overcome
Yeah.
so that the patient can be in a better physical state.
So, in your patient, which on arrival block will you think of?
Ma'am, since it is a distal femur shaft fracture, I can go ahead with a femoral nerve block, or I can choose a fascia iliac compartment block.
I'll request Dr. Kenya to, elucidate further on arrival blocks. She has
Yeah.
said I can give this, that, and so on. So, what is your verdict on that?
Yeah, so definitely, as Arundhati mentioned, that this would be helpful in a patient who has a trauma and is in agony, and which will ease our and surgeons' comfort also. So, definitely, the advantages are these are site-specific block to be considered, which gives immediate pain relief, and definitely it reduces the stress response to tissue trauma. And we can, after giving the block, we can consider tying a tourniquet without causing any pain. So it is easy to apply the tourniquet if there is any massive bleeding, and it permits the patient, I mean, for us to have a detailed clinical evaluation, history wise, examination wise, and for surgeon also. And definitely with pain relief, there is easy transportation for CT, MRI, or other diagnostic procedures. Having said that, though it feels very attractive, but there are certain prerequisites to be followed. So definitely we require resuscitative equipments and drugs along with monitoring, close monitoring, once we give the block. And these blocks being given in the EMT, and the requirement has to be fulfilled over there in the form of expertise and along with the USG. And these blocks should be, I mean, the one who is giving the block should have a sound knowledge of anatomy, considering osteotome, myotome, and dermatomes. So, which particular block to be given for which type of trauma? It has to be defined and then permitted to give. And similarly, appropriate selection of the patients is also must, because the patient might have bled and he might have other comorbidities as well as the coagulopathy. So we need to see which blocks, either superficial blocks to be given or deeper blocks. Then we need to consider these comorbidities as well as the coagulopathy if the patient is having because of the trauma and massive bleeding. Surgical coordination is also must, because for surgical team and EMD team, the resuscitation takes the priority naturally to stabilize the patient. And we have to coordinate. Once the patient is stabilized, we can consider giving honorable blocks. And definitely the finances, the office sanction for the same, because it involves the USG, then the other equipments and the drugs. So this aspect has also to be considered. Uh, and the cautions and the consideration that we need to consider is the pre traumatic nerve injury and elicitation of the nerve trauma and their recording documentation of the same. At the same time, when we are giving the block, we definitely, the after effect of those block like phrenic nerve injury or the stellate ganglion block and the Horner syndrome should be taken into account and should be made aware. The surgeon should be made aware of that. And we also need to be taken care of these side effects, we may say, like phrenic nerve paralysis or the stellate ganglion, where the Horner syndrome is seen. And in that case, neurological examination may be hampered. Again, as mentioned, compartment syndrome, though the possibility is very rare, but patient may just cannot won't complain or if there is any compartment syndrome. The painful symptoms of the compartment syndrome may be overlooked or may not be presented. So we need to be aware of that. Again, giving optimal position for these blocks when the patient is already in pain, and that too in a EMD, there might be difficulty in giving positions. Again, one or two blocks we can consider, but if the patient has multiple injuries, then which block to be prioritized, the volume of the drug, and number of the blocks to be given has also need to be considered. So all these are the important aspect to look after when we see on-arrival blocks. So definitely on-arrival blocks are a very important modality to make the patient comfortable. But at the same time, we have to look that in our busy schedule of, I mean, it has to be a very, very well planned team approach to give the on-arrival blocks, considering all the aspects.
Absolutely agree with you, Dr. Kenya, that on arrival blocks require a team management, lot of prerequisites to be considered, and the cautions and considerations to be kept in mind. So it's not that easy to go and give on arrival blocks. So it is a teamwork, and the teamwork can be slowly enhanced in any particular institute.
Yes.
Arundhati, coming back to your surgical coordination,
Yes, ma'am.
can you go back to that slide, please? You have spoken about urgency of surgery also. You have written about urgency of surgery.
Yes,
Your
ma'am.
the distal fracture. Is it an urgent? Do you think that this is an emergency procedure which needs to be brought on table